Good afternoon for in your country, because in my country is evening, is good morning. Sorry. Thank you for this invitation. My name is Paulina Cisneros. I'm going to talk about endovascular surgical decision for the treatment of diabetic foot ulcer. So I have not had a financial interest in affiliation with any organization. So diabetic foot ulcers are an injury to all layers of the skin. As a result, peripheral neuropathy or peripheral artery disease in patients with diabetes. The incidence of the diabetic foot ulcers continue to increase throughout the world. This is 15% of patients with diabetes and will experience this ulcer in the future. The prevalence is now precisely known, but is estimated to be 4 to 27% around the world. And the risk of amputation is the 15 to 46 times higher compared to diabetic without diabetic. The amputation rates are still high from 16 to 25/16. It's interesting that. About the disorders of wound healing in diabetic, it is important to take into account to the relation with some disease exist. For example, sustained hyperglycemia, or pro-inflammatory environment, or peripheral vascular disease, or peripheral neuropathy. And this produce altered immunity cell function, ineffective inflammatory response, or endothelial cell dysfunction, for example. Thus, this produce abnormal wound healing. This is important for us because it's important. Consider we will have a vascular injury at some point in this patient who have diabetes. And this article recommends that in an ulcer doesn't heal in more than 4 weeks, we should do endovascular or surgical treatment for any of them. So when to refer? When is the time optimal? When you refer. The patient with diabetic foot ulcer or infection should have foot perfusion measured by the ABI. Ankle or pedal Doppler artery waveforms, and either to systolic pressure or transcutaneous oxygen pressure. If ischemia is detected, prompt referral to a vascular surgeon is recommended for ischemia assessment. Wi-Fi staging and appropriate recommendation for limb salvage option. The choice of intervention depends on the degree of ischemia, the extent of arterial disease, the extent of the wound, the presence or absence of infection, and the available expertise. About the management of patients with critical limb ischemia, there is a big difference between American and European guides. The American guidelines don't require an adequate classification to guide revascularization or its result, while the European guidelines recommend the use of Wi-Fi and glass. Okay, so as you can see, Wi-Fi classification system evaluate the 3 main risk factors for amputation risks: wound, ischemia, and foot infection. Predict amputation risk more accurately. Compare progress between groups or patients undergoing different therapies. Okay, but it is important to know about the major gaps in the management of the PAD. It will be needed to increase the awareness and understand of PAD and improve the diagnostic approach, management, and prognosis of PAD. Glass maybe is a useful predictor of immediate technical failure and longer term clinical outcomes. With this one, we can choose the supposedly ideal procedure for infrainguinal treatment, and results have been seen that are related to retrograde access in endovascular treatment. About the IBUS is important for me. In our experience, these systems, glass or Wi-Fi, could guide a therapy. I don't think so, though. Could they truly guide a procedure? I don't think so. It is important to evaluate the plaque, its morphology, its histology, and the IBUS has proven to be a totally useful tool. The critical ischemia represents 1 or 2% of this population with peripheral vascular disease. It's important that. And the outcomes of patients with critical limb ischemia is interesting because once they receive the best initial treatment, die in 25%, are amputated in 30%, continue with CLI in 20%, and resolve in only 25%. It is worrying. Within the first 3 months, the critical limb ischemia is possible to present mortality 9%, myocardial infarction, stroke 1%, amputation 12%. It's important to consider this because in the first 3 months, in related evolution of peripheral vascular disease, critical ischemia evolution at 1 year is possible. The people amputee is in 20%, present cardiovascular mortality in 25%. Alive without amputation 50%. Is worrying, yeah. In this case, the morbidity and mortality secondary to cardiological complication after revascularization of limbs due to critical ischemia is high. However, if critical limb ischemia patients undergo coronary intervention, there were no fatal events during the 4 years of follow-up. This is interesting. So when I speak about the difference about the guidelines of American guidelines or European guidelines, it's interesting because American guidelines do emphasis in interdisciplinary care team should evaluate and provide comprehensive care for patients with CLI. But European guidelines don't mention this recommendation. It's interesting because in this disease, in this pathology, it's important participate in team. When we talk about management of patients with clinical limb ischemia, the direct artery line is important and patent plantar arc is important because these allow limb salvage, and the proper follow-up is correct for a multidisciplinary team: vascular surgeon, interventionist, infectologist, nutrition, and endocrinologist, cardiologist. And the treatment goals in patients with critical ischemia is based in easy to pain, allow wound healing, regain or maintain ambulatory ability. Restenosis is not a problem and many times not accompanied by clinical deterioration. It's important to know distribution of the atherosclerotic vascular disease because many patients present this pathology and distribute in all arteries. Is frequent. Is frequent combined with superficial femoral artery in 30%, for example. So, which is the revascularization option, which is the better, maybe best, better, endovascular or bypass surgery? There is a paucity of high quality data available to guide the clinical decision making. Sorry. And unfortunately, there is a paucity of high quality data available to guide this clinical making. Yeah. And the evidence gap, this is a huge evidence gap. Where cardiovascular pathology present greater evidence and invest in a study than CLI. For this reason, basing ourselves on a single study to guide our conduct with patient with CLI is highly controversial. About the surgical revascularization, the majority of open surgery for lower extremity revascularization is performed for CLI. Approximately 40% of all lower extremity revascularization procedures performed in the United States are open bypass surgery, and the others is endovascular. Okay. It's important to know the infrainguinal surgery produce some complications. Is frequent this complication about the infection or myocardial infarction or surgical mortality, acute leg ischemia, surgical revision. About this study is important to know because the best is the study with 2,100 patients from 160 sites, where is the goal were assess clinical outcomes, quality life, cost, and value in patients who are candidate for both vascular surgery or endovascular therapy. But it's important because we are waiting for its result that will clarify some doubts. In percutaneous revascularization, this technique has a lot of evidence and is very varied. However, we don't have more comparative study with surgery, which is a limitation. In addition, we can see good results. After 2 years of infrainguinal intervention, which is a challenge for us interventionists. But this disease, this procedure, this technique is good because present a good results. So about the factors influencing treatment success, it's important mention occlusion time, length and morphology, calcification, presence of collaterals, distal flow, historical sources rate 70%. When the people are going to talk about conventional balloon, drug-eluting balloon, stem balloon, rotablator, for example. In this moment, this dispositive show many results, a good result. The bibliography shows great results because in recent years, they have improved their technology, their ability to deliver the drugs under the different platforms that resist acute recoil. Although a meta-analysis has reported an increase of mortality in patients receiving paclitaxel drug-eluting stent and drug-eluting balloon, compared with controls. Yeah, but there is some recent evidence against this finding. Nonetheless, the continued use of these devices should be individualized and careful, balancing the risk and benefit. It's important. Consider that. So what is the indication for endovascular revascularization and incomplete lesion? It's important to consider no candidates for surgery, no vein available, no vessel objective, diffuse and severe dermatitis below the knee, failed pharmacological therapy, exercise intolerance, multivessel disease and critical ischemia. In claudicants, to guarantee at least one permeable vessels. So In relation to endovascular treatment, there are multiple devices, but it's important to individualize each patient.
Maybe Dr. Paulina,
yeah?
Excuse me, 2 minutes, please.
Yeah, okay. We'll talk about indirect revascularization. It's important to mention the results of direct revascularization are superior to indirect revascularization. But in some studies show indirect revascularization is not inferior to direct revascularization when the patient have many collaterals. Okay, so is there a food without possibility of salvage? Yes. In this moment, arterialization is mentioned that a good technique, yeah, because it presents benefits even after the bridge has occluded. Okay, so the conclusion: the Society of Vascular Surgery has developed 2 limbs staging, Wi-Fi and global, that permit assess the risk of amputation after the vascularization. Is important care must be taken in the interpretation of objective assessment of perfusion in patient with CLI to appropriate select for revascularization. When surgery is performed for CLI, bypass to the popliteal or infrapopliteal artery should be constructed with autologous vein. Is important. An evaluation for revascularization option should be performed by an interdisciplinary care team before amputation in the patient with CLI. Use of angiosome direct endovascular therapy may be reasonable is patient with CLI and no healing wounds or gangrene. Indirect revascularization is acceptable in the presence of abundant collaterals. And arterialization could be an option in food without the possibility of rescue, but more studies are required. The most important thing is to individualize patient to decide on the appropriate therapy. Thank you.